Now I am going to present how to evaluate the male fertility. In our routine clinical practice, we often evaluate the female factor extensively, but we fail to evaluate the male factor. In almost 30% of the cases, male factor is only responsible for the infertility. So, almost in 27 million couples in India are suffering from the infertility. On the other hand, infertility is rising in the Indian men. A meta-analysis in 2022 led by Hagi et al. Reported that sperm concentration declined by 53% over the past 40 years. 1 in 20 men currently facing the reduced fertility. The use of ART is increasing at a rate of 5 to 10% per year. Coming to the etiologies of male infertility, it can be pre-testicular, testicular or the post-testicular. In the pre-testicular causes, it can be hypogonadotropic hypogonadism, or in the testicular causes, it's like Klinefelter syndrome or testicular tumors, or in the post-testicular causes, it's like infections of the epididymis or the ejaculatory disorders. So these are the factors that are associated with the male fertility. So in almost 30% of the cases, it is idiopathic male infertility. So we don't know the cause of the infertility in 30% of the cases. And mal-descended testes, urogenital infections, hypogonadism, all these are associated with the male infertility. So today our contents or discussion will be, is routine semen analysis is enough? Shall we do DFI for all? When to start our hormonal evaluation, imaging and genetics in the male infertility? Whether we can treat the sperm or we can treat the man. So what the guidelines say? So coming to the components of the evaluation. From the history, physical examination, semen analysis, advanced sperm function test, endocrine genetic ultrasound and the testicular biopsy. These are the things that we have to evaluate. First is the history. In the history, age is very important factor. Like in the females, in the males also, as the paternal age increases, the sperm chromosomal anomalies will increase, and the trisomy 21 and the achondroplasia, all these will increase. In the sexual history, we should ask about their libido, any erection problems, ejaculatory problems, timing and frequency of the coitus we have to ask. And in the family history, like history of infertility in the female, in the family members, mainly in the male siblings, and cryptorchidism, congenital absence of the vas difference, all this will run in the families. In the past medical history, any history of diabetes, hypertension, all this will ask. Then coming to the any usage of antihypertensive drugs, antidepressants, anti-epileptics and antiviral drugs. And any exposure to the tobacco or excessive usage of the smoking, caffeine consumption, stress or exposure to the pollutants, all we have to ask. A recent study conducted what it shows, excessive usage of the cell phones also, it will affect the sperm quality, and exposure to the pesticides, pollutants and the dyes in the industry, all they will affect the semen quality. So in the physical examination is very, very important. In the physical examination, we have to see height, weight, secondary sexual characters and gynecomastia, any scars in the abdomen and inguinal area, position of the penis, and a scrotal examination for testicular size, epididymis and vas difference we have to examine. Because congenital absence of the vas difference, it can only be diagnosed in the physical examination. Then presence of varicocele or not, because only clinically palpable varicocele is only the important thing that we have to evaluate. Then coming to the investigations. First is the semen analysis, hormone test, genetic testing and ultrasound. First is the semen analysis. Semen analysis gives a descriptive picture about the spermatozoa. It does not necessarily confirm whether the man is fertile or infertile. So only based on semen analysis, we should not tell a patient whether he is fertile or infertile. So proper semen collection is very important. For proper semen collection, at least 2 to 5 days optional should be there. The method of collection is masturbation. The laboratory collection is ideal than the home collection, and there should be no spillage of the sample. In the standard semen analysis, we will see for, in the macroscopic, we will see for liquefaction, viscosity, volume and pH. In the microscopic examination, we will see for agglutination, concentration, motility, morphology and pus cells. First is the macroscopic examination. So if there is delayed liquefaction, that is if it is liquefaction more than 1 hour, then it is delayed liquefaction, which indicates infection like prostatitis and seminal vasculitis. If there is increased viscosity, if that is the sample is hyperviscous, then it also indicates the infection like chronic prostatitis and seminal vasculitis. So if the sample is hyperviscous, then it will affect the evaluation of the sperm motility. Then coming to the volume, normal volume is 1.5 to 5 ml. If there is no semen at all, it is aspermia. If there is very less than 1.5 ml of the sample, it is hypospermia. Mainly it is, we have to identify if it is very too short abstinence or any loss during collection or the congenital absence of the vas difference. If it is hyperspermia, then it indicates prolonged abstinence or the accessory gland infection. So, if the low semen volume is associated with azoospermia, it will indicate the congenital absence of the vas difference or the ejaculatory duct obstruction. If the low semen volume is associated with normal sperm concentration, then first thing what we have to ask the patient is any spillage of the sample or the partial retrograde ejaculation. So, normal pH is 7.2 to 7.8. If it is elevated pH, we can see in the infections. If there is low acidic low volume sample is there, then it will indicate a obstructive azoospermia. In the microscopic examination, so if there is no ejaculate, it is called aspermia. Less than 40% motility is there, it is acinospermia. Or if there is no zero sperms are there, it is azoospermia. And based on count, if it is less than 15 million, it is oligospermia. 10 to 15 is the mild, and 5 to 10 million is the moderate. Less than 5 is the severe. And based on morphology, if it is less than 4%, it is teratospermia. So these are the WHO 2021 criteria. So compared to WHO 2000 criteria, only slight little bit change is there. Mainly in the sperm concentration from 15 million to 16 million, and in the progressive motility from 32% to the 30%. And the morphology is same in both the groups. So any abnormal semen analysis report, it must be confirmed by at least two reports in 1 month gap. So routine semen analysis is poorly standardized, it is subjective, it's not a powerful indicator of the fertility. And what we don't know is the functional ability of the sperm. So only semen analysis, based on semen analysis, we should not tell a patient whether he is fertile or infertile. Then coming to sperm DNA fragmentation. Mainly men with poor semen parameters having higher chances of the DNA fragmentation. If the DNA fragmentation is less than 15%, it is excellent. 15 to 30 is good. And if it is more than 30, then it is poor factor. Then coming to the, when we will do the sperm DNA fragmentation in unexplained infertility, recurrent pregnancy losses, multiple IUI failures, and low implantation rates in IVF, we will do DFI. So in the microscopic examination, we also see for a leukocytes. If it is more than 1 million, we will suggest the leukocytospermia, then we will advise a semen culture. Then coming to the one important aspect, like when will we do ultrasound? So there are two things. One is the scrotal ultrasonography, another one is the transrectal ultrasonography. So if we are seeing for any masses in the testis, then we will advise scrotal ultrasonography. For any ejaculatory disorders like post-testicular causes, if you want to examine, then we would advise transrectal ultrasonography, mainly in cases of low semen volume, ejaculatory duct obstruction, congenital absence of vas difference, we will advise transrectal ultrasonography. So, the importance of varicocele. In almost 40% of the men evaluated in the male infertility will have varicocele. The current indications for the treatment of varicocele are only clinically palpable varicocele with deranged sperm parameters should be treated. Ultrasound detected varicocele, there is no need of any treatment. So this is a study based on in infertile men with a clinical varicocele without any treatment. The success rate of IUI is 10 to 16% and the success rate of IVF is 31 to 47%. And after varicocele correction, in IUI it is 7.7 to 15% and in IVF it is 30 to 62%. So, in couples seeking fertility with ART, varicocele repair, it will offer improvement in the semen parameters. Then, when will I evaluate hormones? So, hormonal evaluation we should perform if the in abnormal semen analysis, like if the semen count is less than 10 million and impaired sexual function. So the hormones we evaluate are the FSH, LH, testosterone, thyroid and prolactin. So if the FSH, LH and testosterone all are low, it is hypogonadotropic hypogonadism. If the FSH is elevated, testosterone is low, it is hypergonadotropic hypogonadism. If all are normal, it might be a obstructive azoospermia. We have to look for any obstructive causes. Then role of testicular biopsy. So testicular biopsy we have to do only in club with cryopreservation. So if you have a facility of cryopreservation, we have to do testicular biopsy. Then role of genetic testing. In cases of recurrent pregnancy losses, recurrent IVF or ICSI failure, family history of genetic abnormalities, or if there is any azoospermia or severe oligoasthenoceratozoospermia, we advise genetic testing. Mainly one is the karyotyping, Y chromosome microdeletion, and another one is the CFTR mutations. Then coming to the treatment, whether we can treat the man or whether we can treat the sperm. First, optimization of the man. So we have to advise the patient to quit the smoking, to reduce alcohol intake and caffeine intake, and to reduce the weight, to increase the frequency of ejaculation, to reduce sugars, stress and exposure to the pollutants. And in the medical treatment, we advise the patient to take antioxidants, and if there is infection, we advise antibiotics. And in cases of mainly idiopathic male infertility, we advise anti-estrogens like clomiphene citrate and the letrozole. Then coming to the optimization of the sperms, these sperm selection methods will be covered by our embryologist. So finally, if there is azoospermia, we will see for FSH, LH and testosterone levels. If it is hypogonadotropic hypogonadism, we will treat with medical management with HMG and HCG. If it is a non-obstructive azoospermia, testicular causes, then we have to advise the patient to go for a karyotyping and Y chromosome microdeletion. For that, there is no medical treatment, and we have to do micro-TISA with ICSI or the donor semen. If it is obstructive azoospermia, then we have to take the sperm from testis, that is testicle, from TISA or PISA with ICSI we have to do. So take home message is, male infertility is a growing concern. Lifestyle factors should be repeatedly stressed upon. We have to do physical examination. Semen analysis we have to do. We have advised the patient only in a standardized lab, and any abnormal report should be reconfirmed by second report. And the total motile sperm count is a better indicator. Isolated teratozoospermia should not be stressed upon. If there is pyospermia, it should be treated with antibiotics. And ultrasound is not a replacement for clinical examination. Subclinical varicocele, it is not an indication of treatment even in the presence of infertility. And trial TISA, it should be done only in centers with cryopreservation available, and donor semen is the last option. Thank you.